Good evening, dear friend and colleague. Uh, I want to thank you all for attending this seminar and special thanks for who attended all our webinar during this month. Today, we conclude our interventional month webinars under the umbrella of the Lebanese Society of Cardiology and the full support of Dr. Malik Mohammed, the head of the Lebanese Society. This webinar allow us to escape and forget this epidemic of COVID-19 even for a few hours, and it has helped us to return mentally to our daily practice of interventional cardiology. This webinar is sponsored by Boston Scientific. We are very grateful to people in Boston Scientific for their support. Today, we'll approach the calcified lesion and will benefit from the experience of Dr. Edis, the head of cardiology department at Semi Lewis University Hospital in Hungary, that we thank him for his time to join the Lebanese Society of Cardiology. And we thank Dr. Abdullah Arbez, who will moderate with us and Dr. Malik Muhammad this session. And welcome Dr. Radi Shaitu and Dr. Emil Mhanna for presenting each a clinical case permitting to overview the strategies to approach calcified lesion. I leave the floor. We cannot tell the floor in this time. I will leave the screen to Dr. Radi for the first clinical case. Thank you, Dr. Radi.
Thanks for all the members of the Lebanese Society of Cardiology for this kind invitation. I will present you a rapid complex angioplasty in calcified lesion, mainly the use of rotablator in cardiogenic shock. My patient characteristics was he was 65 years old. His past medical history was noticed with aneurysm in the ascending aorta treated by stent. His risk factors was he was diabetic, hypertensive, dyslipidemic, and heavy smoker. He was under treatment with perindopril, amlodipine, clopidogrel, and Janumet. His clinical presentation to emergency was with acute coronary syndrome with ST depression in inferolateral wall with highly elevated troponin level until 16.7 nanogram per milliliter for a normal inferior to 0.03. Upon admission, he was in cardiogenic shock and his blood pressure was around 75 over 45 millimeter Hg and his saturation in oxygen is around 90%. We go to rapid cardiac ecography, which was difficult in analysis, but we can show an inferior and lateral hypokinesia with ejectional fraction around 30 to 35%. We started directly with classical acute coronary syndrome treatment with associated with dobutamine. And we go to cardiac catheterism rapidly. His cardiac catheterism, I will show you the views for this cardiac catheterism that shows a total occlusion in the mid-circumflex, a borderline lesion in the mid-left anterior descending artery. Here another view for the circumflex, which is totally occluded, probably thrombotic and calcified. And this is the RCA that shows a subtotal lesion calcified in the part proximal of the RCA. Second view in cranial for this RCA with TIMI3. So what shall we do here in this context? This is another view. Excuse me here. Okay. Here another view in caudal for the total occlusion for the circumflex, and we go rapidly to insert here an intra-aortic balloon pressure by femoral axis. The decision was taken here rapidly to go to open the circumflex artery. Here we notice that we go to use an extra backup 3.5 with a BMW wire that can cross easily the lesion, and it is very rapid. We go here to stenting the circumflex with 2 stents in the proximal and mid part with Flow 3, and yes, here another view here. This is the result for the angioplasty of the circumflex with good result, but we think that the problem is not solved here. Also, the patient was always in deterioration in hemodynamic parameters. The blood pressure was around 75/45 millimeter Hg. Although we have inserted an intra-aortic balloon, we have treated the possible first culprit lesion, but the patient rests in hemodynamic deterioration. So rapidly we want to take a decision. What do you think?
Thank you. I think obviously great job on the circumflex, and I would have done exactly the same. The circumflex had Timmy 2-ish flow and is a big circumflex and almost co-dominant. And that's exactly where I think all of us would have started. And no one can argue with the balloon pump when you're working with a pressure of 70, despite the randomized clinical trials that we're all aware of. And that's a bit controversial, but all of us who do this on a daily basis would feel better working on this patient with an intra-aortic balloon on top of the dobutamine you started. And then once you achieve that flow in the circumflex and you still haven't stabilized the patient, now you have another critical lesion in the RCA, none of us, I think, would leave that lesion at this point. Had he been stable, we can argue about staged or not staged and how much contrast you gave. But I think at this point, you have to move to the second lesion, and we all agree on that.
Exactly. So after this persistence of unstable hemodynamic, especially that we have ischemia, severe ischemia in the inferior wall and the lateral wall, we go with GR 4.0 with BMW 0.014 that cross easy the lesion. We go to pre-dilatation of this calcified lesion with a balloon 2.0 and 2.5, and we have estimated angiographically that the lesion is open. So we try to cross the stent, to cross the lesion with the stent, but we cannot. We go to body wire technique. We put another wire in the RCA to cross the stent, but also we cannot. So.
Dr. Radi, in this time, the patient, what is the situation of after like minutes or 10 minutes after the first procedure? The patient still in shock when you are trying to do this right calcified lesion with the GR4?
Yes.
Did you try it before you want to? I saw that you changed your guiding. What are your please in charge here to go for changing the guiding?
Especially that we cannot cross the lesion. We notice that the anatomy of the RCA, it goes mainly with the omplatz. I cannot put an omplatz AL1, so I choose the AL 0.75 to increase the support in the target to cross, to have the ability to cross the stent. Unless this, I think that we have doubt that we are not in the good lumen after crossing 2 wires in distality. So I go to microcatheter and distal injection to verify if we are good or not. Although the use of omplatz AL 0.75, I cannot cross the stent from the lesion. So that's why I changed the guiding rapidly, and the patient is still deteriorated in hemodynamic.
Why you will use the microcatheter in this situation, even though with the GR4 your wire is passed rapidly.
Yeah.
Because if we see here, we have a contrast on the limit of the aorta. Any dissection has done with your GR4, and this is the dissection of the RCA is here with the first procedure. What do you think, Dr. Abdullah?
Yeah, I think we're all, all of us have our eyes on that bit of linear opacity in the aorta. Obviously, sometimes you're so caught up in the lesion, you'll have to go back to the first shots to see if this was just calcium on the aorta or if this is contrast. But instrumenting the ostium of the right with the first guide and having difficulty, we can see this, and some mild dissection in the ostium, which at the end of the case, hoping it will be successful, all of us would stand the right coronary all the way to the ostium and have a clear conscience about this.
So that's why it goes after crossing of the second wire and injection with the microcatheter, we feel not good with the flow. So that's why I cross the final crossing distality to check if we are in the good lumen or not. And we noticed that the calcium in at the entry of the ostium of the RCA, we can notice from the beginning of the procedure.
Dr. Edis, what do you think in this stage? Because we have a cardiogenic shock, we stent the culprit lesion, and here we are trying to treat the another lesion on the RCA. And in our daily practice, we have like this complication. We don't need it, but it's happened. It's a very calcified lesion that is not dilated by any balloon. Need to change the guiding, and we don't know if we are induced any dissection. For that, Dr. Radi have to be very sure where he is with his wire, take a good decision, taking in a microcatheter to inject in the microcatheter to see he is in a true lumen, to take the decision for this probable dissection or TIMI that is changed before in the first injection and the latest injection. What do you think in this stage? How we can take an approach in this case? And this is our daily practice in intervention cardiology. We don't know what will happen after starting a complex procedure like this.
Yes, I'm quite familiar with the situation that you've presented to me. My daily practice also involves patients with high likelihood of the one that you just told me. I have to agree with Dr. Abdullah as he said that you cannot be sure that what you see above the catheter at the moment is indeed a dissection or not. I'd rather say it is not a dissection. I think it is intrinsic calcification of the aorta that we see. But to be sure, we have to check the first slides or the first, angios, especially the one where when you have not cannulated the right coronary artery yet, during the left injections, and if you can see still the scar upstairs, then you can be quite sure that it is a calcified lesion.
prednisone ولوبينوكس مثلا واسبرين وانتيبايوتيك اذا مش اخذ
Thank you. Also, I agree with the fact that you use the microcatheter in this situation to inject into the distal RCA. I think it's in the correct position at the moment. I must also state that very heavily calcified anatomy and very heavily calcified right coronary arteries are less prone to dissection as those, for example, of a young patient without so much calcium. So calcium also has some positives, like I said. So in this situation, what we see at the moment, how I would advance the procedure is advance a floppy rotowire through the microcatheter, remove the microcatheter, and start a rotational atherectomy with a 1.5 milliliter burr at about 160,000 K.
Yes. So here we proceed to go to after changing of the wire, choosing another balloons. I don't have an OPN balloon, although I think to take an OPN balloon, but I didn't have at this time.
It would be impossible to reach you to the OPN balloon.
Yes, yes. I think for this, because the OPM balloon, the profile of this balloon is not a good profile. And with the mother and child, because I introduced the mother and child to cross the lesion, but I cannot, because the lesion is very calcified and fibrotic. So unless if I have the OPM balloon, I think after the difficulty to cross with the mother and child, I will not use the OPM balloon because it will be very difficult to cross the lesion. So many solutions to modify the lesion here. I will go to some of review of literature in treating such lesions. I will return back to our case. One of the possible solutions for this patient is rotablator. And rotablator clinical utility, as we know, the calcium is a growing problem that can negatively impact PCIs if left undertreated. So calcium is really prevalent in patients undergoing PCI. I will show here the diagram published by Philippe Généraux on 2017, the sum of 14 DOS studies that conclude the number of calcified lesions in these studies, like Ravel study, Sirius study, Taxus study, Compass study, ADAPT DOS study, all of them, the approximately, we have 30% of calcified lesion in these 14 DOS studies. So the need to treat calcium is growing up and up, especially in increasing of risk factors, such as the age, diabetic patients, renal failure, hypertension, and smoking. And in new technology, such as high-risk PCI and before TVR. So calcium treatment needs will continue to grow over the next 10 years. And calcium leads to worse clinical outcomes. I will show you in brief summary this table from Horizon AMI study and Acuity trial, around 6,855 patients in acute coronary syndrome pooled. We can notice the augmentation of MACE with the augmentation of calcium in these patients treated. So the calcium can play a worse role in outcomes after 1 year of stenting. And calcium can inhibit optimal stenting also. Such complications due to calcium before PCI, like dissection during balloon angioplasty or predilatation and difficulty with complete dilatation. During angioplasty, inhibition of adequate stent expansion, prevention of stent delivery to desired location, and the stent under expansion or malapposition. And we can notice post-angioplasty, many studies say that the drug penetration was insufficient, especially in circular calcified lesions when stenting. So subsequently, we noticed the restenosis intrastent in the first year. Rota can modify the plaque to change lesion compliance. And I will list for you the more 6 benefits of rotational atherectomy for lesion modification. First of all, minimize vessel trauma. Second, enable lesion access. Third, facilitate stent delivery. Fourth, optimize uniform stent apposition. Fifth, create larger MLD. Sixth, avoid rotarograde. So it's the 6 more effective benefits of rotational atherectomy. And for the 6th part, to avoid rotarograde, I will present you from the review of literature, a heavy calcified lesion in the part proximal of the RCA. The operator go to stent directly in the figure 1 with a stent to 2.75 millimeter stent placed. Look for the result in figure 2. Result subintimal. He go to post dilatation with 3.5 times 9 millimeter non-compliant balloon for 30 seconds at 22 atmosphere, followed by 4.0 times 9 millimeter non-compliant balloon for 30 seconds at 16 atmosphere for a stent to 2.75. And the result finally was really suboptimal. So lesions which initially appear as either treatable with PCA or by stenting may benefit from pre-treatment with rotablator rotational atherectomy system. Using rotablator system may favorably impact calcific complications like acute angiographic result, TLR, and angiographic restenosis in calcified and complex lesions. And this is very important key point. The asymmetrical stent expansion occurs in up to 50% in the studies of cases where calcium is not treated before stent deployment. atherectomy is only used in 2% of all PCIs globally, which is unbalanced with the level of severe calcium. Ease of use and set time are some of the most common reasons listed for not using rotablator in market research, and the price, especially in Lebanon. Rotablator has been on the market for 25 years, and innovations in technology are available to improve the system. So to return after this few slides for review of literature to treat this patient, in our case, we have persistent of unstable hemodynamic, severe ischemia in inferior wall, lateral wall, intra-aortic balloon pressure, opening of the circumflex. The patient was still in unstable hemodynamic, so I choose to go to rotablator with rotational atherectomy with 1.5 burr that cannot cross the lesion for the first attempt at 150,000 tours per minute. Second attempt, I cannot cross. I raise the tour to 180 tours per minute, and here I can cross the lesion with the 3 cross rapidly, unless the rotablator march very well and intra-aortic balloon in place. I cannot cross the stent. I return back to mother and child, 5 and 6 guiding catheter to cross my stent. And here the first stent, as we have discussed initially, because I have a doubt for the ostium of the right, so I must cover the ostium of the right until the lesion. I have a small dissection at the end of the stent. I put another stent at the edge of the first stent, and this is the final result for the RCA. The Tamiflu is not clearly 3. I have a small slow flow because of the 5 and 6 is in the guiding catheter, and here I have a nice result for the, if you agree with me. So,
Dr. Rati, I want to ask you, after rotablation, you need a mother and child to cross by the stent?
yes.
Even so, with the after rotablator?
Because I have a very weak support, although I use the AL 0.75. This is the support. I'm sure that I debulked the lesion, but I'm not sure that the tortuosity from the CD1, RCA1 to RCA2 enable me to cross the stent. So I have the 5 and 6 utilized. Donc I used the mother and child to cross the stent in the first proximal part after exchange wire with an BMW.
Did you do ballooning after rotablation? Because we know that after rotablation, we have a cracking of the calcium,
Yes.
and we can optimize the lesion by the NC balloon on the 1-to-1.
Yes.
Did you do that?
Yes. Yes.
And even so, the stent cannot pass.
Yes.
I want to ask Dr. Abdallah his opinion and Dr. Idris about, in this case, because putting the rotablation in place, we have, for example, a shockwave balloon that is rapidly can be deliverable in the site of the cath lab. Did in these cases the shockwave balloon is an indication, can be indicated, can help us, or the rotablation will be the standard of care in this case? Dr. Abdallah.
First, great case, really, because it has so many teaching points for us. I think all of us looking at this lesion, we see the calcium, but I think all of us would have started like he did and thinking, I'm going to get through this with an NC balloon and a stent. And then once you fail with this, is where you have to decide what to do next. Do I change my guide? Sometimes what I do when I have a feeling I'm going to have to change guides and the lesion might not be easy to cross is you can change a guide if you have a long wire, a 300 centimeter BMW wire, while keeping the wire in place, as long as you put another J wire in the aorta. So that's doable. You could have, we could change into an AL without losing access to the true lumen of the distal right coronary. But second of all, I think once you were in a position where you had your microcatheter distally, now you're in great position to put a rota wire in, you're in the true lumen, you have experience with rota. It's a proximal lesion. I think it's an ideal lesion for rotablator, because that is what solved the case really. And then beyond this, again, NC balloon, of course, and delivering the stent. And yes, sometimes so much calcium that even after the NC, the stent, all that could be a tiny angle, and therefore you need a guide extension to deliver the stent. So it's a great case.
Yes. After this, at the end of the procedure, the blood pressure raised up slowly to 95/55 millimeter Hg, but at day 3 post-procedure, clear improvement of hemodynamic parameters, and we stopped dobutamine and intra-aortic balloon at day 3 post-procedure. For take-home messages, 2 messages: interest of complete revascularization in patients undergoing cardiogenic shock. I know that it is a debatable subject, especially after the results of culprit shock trial that insist to go just for the culprit lesion. But here, I think it is case by case. Here we have severe ischemia inferiolateral, cardiogenic shock, subtotal lesion after the opening of the culprit lesion. It is a really debatable subject. I think you are most agree with me to go to RCA angioplasty. And second, if rotablator is necessary in such cases, good support of guiding catheter is mandatory. Small burr. I will notice this just a few ideas. Before, from many years, at the establishment of rotablator, they said that a bigger burr is better. But with going of studies, the MACE is minimal with the using of a small burr. So small burr, good support of guiding catheter, hemodynamic support with intra-aortic balloon, why not? And high speed to minimize the risk of slow flow in cardiogenic shock. And thank you.
Thank you very much. Dr. Ellis, any comments based on this case from your experience?
Yes, that was truly an excellent case, Dr. Abdullah. I have to agree. The only thing I would have done differently is taking a look at, first of all, I would definitely also would have with the RCA PCI opening the circ, so that since the patient was in cardiogenic shock, time is of the essence. You have to have a very clear decision on how you see the future of the case and your patient, and be very diligent in doing this. So what I would have done is wire it directly with a rotowire, probably, and immediately go to rotational atherectomy. This also has to do with the fact that in our cath lab, we do a lot of rotational atherectomy. I myself do a lot. We have lots of very good experiences. And as I said, as time was of the essence, it was mandatory to fix this RCA as fast as possible. I also agree with hemodynamic support. Luckily, at my cath lab, we have the peripheral ECMO available 24/7. This patient, yet, on the other hand, was not really eligible for mechanical circulatory support because of the aorta disease that he had. I think I would also have inserted a balloon pump in this case and done it very, very similarly. So again, congratulations on your case and saving this patient, because this was a young man.
Thank you.
Dr. Minik, any comment?
عم تسمعني علي؟
Very good, very good.
Okay. Good evening, dear colleagues. In retrospect, I have a few comments. For sure, a great case. Thank you, Radi, for your achievement. In retrospect, not all centers have rotablator. This is a case which is heavily calcified coronaries. It's obvious the RCA is even in fluoroscopy appearing calcific. So this is definitely a hardly calcific lesion. Would you recommend, in retrospect, if we opened the culprit lesion, which is the circ, in a shocky state, to attempt opening this artery in a center with no rotablator? Because I think what has been done for this vessel in attempting to open by multiple ballooning wiring is that we lost Timmy from Timmy 3 into Timmy 0, and the patient was in shock. I advise in this situation, if someone is not operator experienced and he has no rotablator aside, not to cope with this artery, because I think the situation will be worse concerning his hemodynamics. Would you approve this or not? And concerning the issue of treating these lesions would be in a stable area went or go from the unstable into the stable condition. Is it okay, this scenario for the all centers who have no rotablator on the table?
I think it is, yes. If you do not have a rotational atherectomy system available, then it would definitely have been a bad idea to start this, because you would have been unable to finish your procedure, and possibly that would have cost the life of the patient in this case. Now, after fixing the culprit lesion, as an interventional cardiologist, when you see this RCA, you do not commit a failure if you do not try to fix this RCA as with the culprit shock trial. As I tried to point out earlier, in this case, I would have begun, despite the fact that time was off, directly with a rotowire, only in a center that has rotational atherectomy. Fix the circ fast. Then if you see this RCA and you have a rotational atherectomy on board, you're comfortable with using it, you're experienced with using it, advance the rotowire as fast as possible, rotablate as fast as possible, use an NC balloon or a scoring balloon. I like scoring balloons very much. Open up the lesion, stent it quickly, and move out of there as fast as you can. And get the patient to ICU, where he can probably be kept for after revascularization.
So, doctor, you recommend after rotational atherectomy to go with a scoring balloon or a high-pressure NC balloon
Yes.
to prepare the lesion mostly effectively, so as we will not have any problems entering the stent?
Definitely.
Okay.
Later on in the session, you will see this in my talk. I have detailed information about this.
Okay, thank you. Thank you very much.
Thank you.
Dr. Edis, from the attendees, there is a question, and I raised it before. What is the place of shockwave balloon? Like I said, in this calcified lesion, the shockwave balloon is, first of all, the balloon has passed the lesion, but it's not very well dilated. I think the shockwave balloon can pass this lesion.
Oh.
Is any
No way.
effect?
Respectfully, I have experiences with the shockwave balloon. We are using the shockwave balloon at our center. To be honest, it's not my favorite device. First of all, it's extremely bulky. It's difficult for it to reach the lesion. So much so that I'd say in about 50% of the cases, prior rotational atherectomy is needed for the balloon to pass where I want it to get. And in a setting of cardiogenic shock, there is actually a contraindication to use the shockwave balloon because it takes time. You have to blow the balloon up at 6 atmospheres, 8 atmospheres, deliver the pulses. It takes time. Delivering the pulses of 10 takes almost 8 to 10 seconds. That means you've occluded the artery for that long. And you have to do this multiple times, at least 5 or 6 times in the whole artery. And in the setting of cardiogenic shock, that occludes the coronary artery for way too long in this patient. So the IVLS, so the intravascular lithotripsy or shockwave balloon, that's only for elective cases, as to my knowledge currently.
Agreed.
Thank you for this answer. And thank you, Dr. Radi. Any comment from Dr. Abdallah before starting and hitting the next case with Dr. Emil?
No, thank you. Great case and great comments.
Thank you very much.
Yes, excellent case, sir.
All right, next, Dr. Emil Hunna will present another case also about challenges of calcified lesions and looking forward.
Okay. Thank you. It's a great pleasure to be here, and thanks again for the invitation. this was a great case. It's tough to match Radi's case by any mean, but basically my presentation, just wait until we share our screen and then. So I'll be showing one case. We'll try to keep it, keep a nice discussion first, and then you showed beautifully rotational atherectomy. We'll try to talk a bit after that about other devices that can modify calcium and set up basically the floor for our last talk, in which hopefully we'll listen where to choose and when. So these are first my disclosures. Now, the case actually was done, and we were doing an imaging course, Tom Johnson and I, and this was 2019. And we had a STEMI during the course. We said, you know what, it's a live course, so let's get the STEMI and see. But we're not expecting a lot of action. You know, you always have planned in these live courses your cases. And then, so an 81-year-old man presenting with an inferior STEMI. And, you know, took the first picture, you can clearly see, I mean, clearly, we already see there's, two lesions there. We shot the left, it was non-obstructive in the left coronary system. And we decided to go, it's primary PCI, you know, took an AL, we said, okay, he's 81, we have calcification, there is some tortuosities in this. Just wired it to the run-through, no issues. And, you know, trying to keep it simple in a STEMI, and we went to 2012 compliant balloon, we could not cross the second lesion. So here we are, you know, we have a guide, we have a wire, and we can't cross. Maybe starting first simple, keeping it simple, maybe ask our panelists here what to do next. You know, we're starting the case, the STEMI, the patient is stable, you know, there's no hemodynamic instability, he's just having a little chest pain. So anyone wants to jump right off to modification? Anyone wants to use some other tricks first?
As working in Lebanon, I will not think directly for a rotablation or other procedure. I will go for a double wire, try to starting with a small balloon and upgrade for greater size, and we'll see what will be next. What do you do, Abdullah?
Yeah, I agree. I think, I mean, all of us have this algorithm of what to do when you can't cross. Problem is, he's 81, there's calcium and there's tortuosity, but trying a body wire, and then if you're successful with the first lesion, at least dilating it, trying a guide extension and see if this helps you. But if not, then obviously you have to move to something higher grade.
Excellent, excellent. So that's basically what we did. Actually, we did a guide extend. You know, we thought, you know, we're already with an amplat, so we had some support. We're not doing a JR there. So we got our guideline, statistics French guideline. We're doing it radially, and then we get it actually across the first one, and we started with a smaller balloon. So combining what you just said, you know, start with a smaller balloon, a bit more support, you know, and then we did our 1.5 balloon. Our 2.0 balloon, you can see clearly, you know, use the 1.5 to bring our guideline. It's a good technique. Also, when we have our 1.5 balloon there, use it to somehow get your guideline so you don't have to have the struggle and minimize the effort you're doing. And then we thought, you know, the first lesion yielded somehow, but then took a 2.5 balloon. And that's, I think that was key, just mentioned earlier by the panelists and Dr. Edis here, to always make sure before you go and stent, you call it rotary gret, you can call it whatever. The no of interventional cardiology is just throw in that stent and then have to battle. So there was clearly a waste on that balloon here, and you know, we got the balloon there, we were upsized, but clearly a 2.5. There was a waste there. There was a non-yielding lesion. So time now maybe for modification. What do you think, guys?
Yeah, I think once you see the shape of this 2.5 balloon, and now you've tried everything and you can't dilate this lesion, and it's calcified, and he's 80 years old. Now you have to go to debulk this calcium, and having the guide extension, and I think this is also room for us to discuss, but the guide extension might help you bypass the first tortuosity, and you can always rota through that usually when we do that, knowing what the lesion looks like ahead of time, it's always better to be a 6 and a 7, because the rota would cross the 6 French guide extension way better than a 5 French in a 6. So 6 and a 7 would be much more helpful here, but I think rota is the way to go here.
Yeah, seeing this lesion, I want really the approach of very experienced doing rotablator, but this 90 degrees is not so easy to go by rota. I will think last at the end of my algorithm to go for rota with this 90 degrees in RCA calcified. I will think twice before going to rota. We have in 90 degrees and the lesion was proximal to this 90 degrees, and we have a lesion after this 90 degrees. If we go to treat the distal lesion, I will think the rota will pass this 90 degrees slowly. But we have a lesion before this 90 degrees, and we have to think really about it before going for a rota with any burr. I don't know what you think, Dr. Edis, Dr. Emil.
That's an excellent case again. Now, taking a look at the image that is moving right now, I think that only the second lesion is the one that clearly requires rotational atherectomy. The prior one can be manipulated enough for it to crack the calcium arch and then eventually stent it. But the distal one, you can see classical BEF, so balloon expansion failure, or the hourglass phenomenon, however you want to call it, as you are trying to expand the 2.0 balloon. Now, the rota can pass this 90-degree arch. It's not too big of an issue. What you have to be careful is not to use it at high speed. So use Dynaglide and advance the burr with Dynaglide inside the artery through this 90-degree arch, and only switch to full speed when you are at vertical section and going downward. This is one case. Have a guide extension inside, you can be extra careful and advance the guide extender itself through this 90-degree arch, and or come out only with the rota head through the guide extension device when it's already in the downward section of the vertical RCA.
Excellent, excellent. Great comments. And you know, we're thinking along these lines, thinking about the tortuosity, you know, the challenges, but also, you know, we had the guide extender, whether, you know, yes, we didn't have a 7 French, but we can still do stuff with sticks. We thought, you know, I mean, I'm very biased in interventional cardiology. I know we're working today in Lebanon with a lot of resource restrictions, but I'm a big fan of imaging. So whenever, and specifically intracoronary imaging. So when there is some, you know, room, or we're not sure what to do, just it's the era of no gas PCI. So we went actually and IVUSed it, and just to have a sense, and you can clearly see, and have still pictures, you can see the pullback, but you can clearly see that lesion, that second lesion that I have. You can see distally, you know, not much calcium burden. Remember, calcium on IVUS, you know, it's that and I'll show a few slides later. It's that hyperechoic area. You can see it clearly. But you can clearly see that you have calcium in at least 3 quadrants, you know, almost 270 degrees. And obviously, that's what somehow you expected, but you know that you need to do something. Luckily, we were just discussing a bit earlier, you know, about you know, shockwave or rota. We would have gotten the same thoughts, you know. It was stable. So, because, you know, shockwave, after all, is a balloon. But we thought we were able to deliver a 2.5 after all. So the patient, knowing, you know, it was clearly he was not sick, so telling us that these are chronic lesions, and now he had just the final hit on that lesion, you know, probably proximally. So based on this, you know, after this IVUS, we decided to go with shockwave. So part of it, again, this was talking again a year and a half ago, it was still like relatively new on the coronary aspect. We said, you know, let's do it. And, you know, and I'll show some slides toward the end how it works on these mechanisms of function. But using, you know, you see our guideliner, really, I mean, we're there, you know, we're taking a bit that first curve, you know, we're there at the first curve. We were able to deliver the balloon. We gave the 80 pulses. And, you know, we were happy. And before anything else, as we were just saying, full agreement with what was mentioned before, before you get your stent, even whatever you use as a calcium modification, get a balloon and make sure the balloon expands, or better also image, you know, and do both ideally, you know. I mean, image, know what happened to this. And here's our image. Here's our image. We have clearly at the area there's crack in the calcium. Remember that calcium that was almost circular? There was a crack in the calcium. And again, we thought they will be fine. You know, we cracked, you know, crack of calcium, meaning that we will be able to expand, you know, because technically, think about it, and we'll talk a bit more about it, and I'm sure Dr. Edis will talk more about his algorithm. But clearly, we got rid of that rock pile there. That's 270 degrees of calcium. However, what we did not expect is, believe it or not, with the guideline in place, we could not deliver our stent. So, you know, there was clearly, you know, like we cracked the calcium, we were able to deliver our IVUS catheter. But made the ideas now. We can't, you know, we have the guideliner, have good support, the wire is distally, you know, but, you know, this combination of tortuosity, this chunk that is there, you know, the morphologies. I know you mentioned a bit earlier trying to, you know, to modify a bit the angle where you're getting, but we couldn't, you know, we tried and we thought we needed to do more. So maybe here, for sure, what we ended up doing is maybe take some ideas, you know. We did shockwave, we cracked the calcium, it's an unfavorable angle. What do you think, Ali, first, what to do then?
Rota, for that, you have to go. If we did, what should you do? Shockwave balloon is one of the strategy. You did it and it's failed under guillemets. And ballooning is not, it's cracked the lesion of the maximum. We're not going for more high pressure balloon for thing, because really every time I use a high pressure balloon or or other devices with high pressure, with 81-year-old male, I think twice with our situation in Lebanon, any rupture of the vessel. I cannot, I have to think direct to the algorithm. Rotablation is less risky for the patient than other going more and more for higher balloon. What do you think, Dr. Abdullah?
No, I think, I mean, you're at a stage now where you've done everything. You've exhausted. You've used the shockwave. You've NC ballooned. You can deliver. You have a tortuous calcified lesion. You haven't gotten rid of all the calcium. That now you're pretty much left with having. I would just go and rota my whole way through it. The fact that I cracked calcium actually makes me feel better going now around this bend, which initially I was thinking I'd rather have a guide extension through, but now I would just rota my way through and through from proximal to mid.
Excellent, excellent. So,
Dr. Edis?
Sorry.
Yeah, sorry, go ahead.
Dr. Malik, you have a comment?
Emil, but I just want to ask Emil, after doing the shock, dilate also after the shockwave with the balloon?
Yes, yes.
And did it waste?
No, actually there was no waste, and that's you know, so we knew like the waste that was there was gone. So
okay.
So basically we knew that crack we caused already like allowed expansion. It was just a problem of delivering that.
So you're the lesion or pre-lesion? I'm sorry, I didn't get the answer. Sorry, there was an interruption in the net. The difficulty in crossing was because of the tortuosity or because of the lesion per se down?
The lesion, the morphology of the lesion. We crossed the first tortuosity. We had our guideliner there, and you know, you whatever you do to modify to get that sense to slide on that calcium chunk, that minimal lumen area, we couldn't. You know, we could get the balloon, we opened it, but for some reason, some morphology of the calcium and the chunk itself, you know, we were still facing trouble getting that you know, low profile stent we've been using.
Even with the body wire?
So we did not use, that's a good question, because, you know, we did not use a body wire, and that's why we're just saying.
So as to try to slide your stent on it?
Absolutely, absolutely, and maybe
Because
that
I don't. Sorry, Emil, I don't see the rationale behind doing more rotational atherectomy. If you already have dilated your lesion very well and your balloon is dilated very well, the atherectomy will not do any addition. I think this is a mechanical lesion obstacle that needs to be treated very well by maneuvering like body wires, guide extension deep into the stand, into the lesion. I think rotational atherectomy, if Dr. Adis will approve my comment.
Absolutely. We'll hear Dr. Edis, and then I'll give you like a bit of the thinking process happening throughout the case. But great comments. Maybe Dr. Edis, your thoughts.
Yes, I agree with Dr. Mohammed. There is nothing to rotablate in this case. Now, if you would advance a rotabur inside this artery, you can measure how large is it. It would basically do nothing. It would physically go into the middle, spin there, and not ablate anything. Yes. So I have to do what's needed here. Use an extra stiff coronary wire, preferably to use a guide extension catheter, and probably you need even a better stent. I do not know what you were using. I seriously have my doubts that rotational atherectomy would yield anything in this case. I would be comfortable with trying to stent this lesion after you have used the intravascular lithotripsy and also post-dilated after shockwave treatment. And you can clearly see on the IVUS that the lesion is cracked. So I see no rationale for further rotablation.
Yes.
Excellent comment. So in general, and I tell you, like in general, I mean, we've been using IVUS here, and we'll take your comments, and I want to mention something. But the biggest usually challenges have been when you think you're good and you see your balloon is a protruding nodule or a protruding chunk that is in the lumen. And that's really whenever, and we've all faced these cases where, you know, it doesn't look that bad. It doesn't look that, you know, angiographically, but still you can deliver stuff. And we thought, at least by the tactile sensation and the feedback we were getting, that potentially, yes, there was a crack in that calcium. And that's why I'm seeing, but clearly there was some nodule of calcium or something protruding into that lumen, hitting that, because of course, it was after trying, you know, all these tricks we try to do every now and then. You have a guideliner, lift a bit the guide, and then pull and push, and you rail it a bit for me, and try to do these tricks, try to get away from that nodule. But at least the thinking process during that case, and again, they're all great comments, because I fully agree with you. It's a STEMI, it's an 81-year-old. You want to be as simple as possible. If you can just, you know, just deliver it, and you're there. But the thought was, it's a nodule, it's something still protruding, not circumferential anymore, yielding on this, but something causing this mechanical obstruction. Comment.
You answered to my question already with your comment, because I wanted to generally we can see a lesion that we dilate very good, but the stent cannot pass, and most likely there is in our way through this lesion, a bulky lesion that is not very cannot see it with only with multiple orthogonal view to see this bulky lesion. Is not generally can be with this anatomy or this kinking that cannot deliver the stent. We can have a bulky lesion, and the stent was hitting this bulky lesion, and the rotablation in this case will solve the problem. You answered to my comment. Thank you.
Okay. So we ended up doing rotablation. I know that Dr. Muhammad and Dr. Enes are probably now nodding their head. No, a disaster is gonna happen. But clearly, I mean, we're playing with fire, because technically you're modifying the curvature of the vessel. We brought back our guide, and and this is really the closest you can get, to trouble there. And yes, it was closest to trouble. You can clearly see here, yes, we got maybe some improvement. We were able to deliver now our stent. We stented, but clearly you will see post-stenting, we did an IVUS post, and then in the IVUS post, we saw that proximally, this is much faster because I just made the video go faster, but you can see proximally, you will see toward the end, that we had still room. You can see it here clear, a bit of under expansion basically, and then we ended up hitting it with a 5-0 non-compliant. Our final view, clearly you can see behind the stent strut, there is a little, dissection. And I said here, the patient did fine. This was not an easy day. It was not a fun day. And we were definitely lucky, and then we were happy after that. He did fine. The patient did fine. And as you can see, while the contrast is washing out, we really sheared that vessel, destroyed the anatomy of the vessel, almost straightened it with rota. We thought it's a good case to set up maybe the talk I'll do next, and then maybe if someone has any comments before we talk a bit about like other approaches. This was basically a case of now a la mode, rota shock, if you want. That's what people are calling it these days. Any comments? Just okay, excellent. So let's again, as I told you, the rules and the tools to win the calcium war. That's how I called it here. And the rule number one is you should know the enemy. We always say calcium is our enemy in the cath lab. And the first thing we should know is know your enemy. And to know it, you need to see it. And to see it, you have two intravascular imaging modalities, intravascular ultrasound and optical coherence tomography, that can add value in these type of procedures. And once you see it, you can choose the right tools. And again, we'll hear from Dr. Edis in his talk about his algorithm and his preferences. But briefly, you have cutting balloons, you have rotational atherectomy that was beautifully reviewed by Dr. Shaito just before me. We have orbital atherectomy, shockwave lithoplasty, the two newcomers, the new kids in the block. And then you have laser atherectomy, which I don't think is available in Lebanon, but which I've had used, and again, we'll show it briefly, and I'm pretty sure we'll talk about it. But when we say intravascular imaging, we should know the signature of calcium on intravascular imaging. We all know that if you don't image, you will underestimate calcium. And if you underestimate it, you're increasing your likelihood of stent under expansion, longer procedures, malapposition, complications, and radiation, and you name it. So it's important to see it, and it has a peculiar signature. These are two chunks of calcium. You can see on the left OCT, optical coherence tomography, a light-based imaging modality in which calcium has a low attenuation and low backscattering with sharp edges. So you can see light going through it. You can see my asterisk on the first left upper corner there. Corresponding to that, we're more used to maybe to IVUS, which IVUS has been there since the 80s, OCT, 10 years now, since the FDA approval. But you can clearly see that hyperechoic and some shadow behind it. These are the signature of calcium. Now, there are parameters that are important when you look at the calcium, and we looked at that. And the key things are to know the angle, the distribution, because it will have, if you have one or two, and I'm pretty sure we'll hear more about it, but in my practice, when you have one or two quadrants, you still have 180 degrees to expand, but when you have a circumferential, that calcium distribution or angle is key. The depth is key in your choice of modality. If you have a deep calcium, you will not reach it by doing sometimes, the usual debulking rotational orbital. And we should always forget, again, the thickness is important, an important parameter. Deep, nodular, superficial, these are different types of calcium. Look on the OCT on the left. This is a deep calcium. See how much intima there is in front of it. This was a nodular calcium, can be easily mixed with a thrombus. And the lower one is a circumferential, but superficial calcium. And things can vary, and I'm sure we'll hear more about that. And when we come to think about calcium is not a two-dimensional. We should always picture it. It's not that frame, It is calcium is actually a 3D structure. Calcium, it's a chunk of calcium. That's what we were just discussing. Some of it protrudes, some of it can be deep. And when we're planning our procedure, and we're trying to see where we want to land or how to improve our expansion, we have to keep this in our mind. So we have to think 3D. I'm mentioning calcium by imaging, but I also have to mention that neocalcium. That's really a hot topic now, this neoatherosclerosis, or this calcium, you know, I'm showing you different healing of stents. You can see in the first picture up there, A is what normally a stent look like. Again, that's OCT here. You have your light source. It's a light imaging modality. You can see the stent struts and the shadow, that are metallic stents. And you see in B and C, you have plaque. You have lipid-rich plaque in B and calcified plaque that formed inside the stent. That's the concept of neoatherosclerosis and neocalcium. And this can be a problem by itself. And I'm pretty sure we've all faced it before the era of imaging. You know, you have that stent and then you go and you try, and then, you know, it's an old stent. You think it's just neointima. You put a stent and you get away with it and you just can't expand. So it can be calcium behind it, causing the restenosis, and you have to modify it, or it can be calcium inside it, and that's another problem. And these are usually stents that came late stent failures with these deposits, you know. Now, we saw calcium, OCT, IVUS. Probably you should use the modality you're more comfortable doing 3 things: acquiring the image, interpreting the image, and reacting to the image, you know. Each one has advantages, disadvantages in some places. You know, osteal lesion may be better in one, you know, stent failure is better in the other. And ideally, again, acquisition, interpretation, reaction, and what you can see and able to interpret and react to. So let's hit our calcium. First thing, specialty balloons. You know, you mentioned OPN earlier, I not included, but these high pressure balloons, you can take them, crank more. You can have the end. I mean, you have the Wolverine balloon, you know, these are cutting balloons, angioscope, you know, I'm showing you examples, but the concept is one concept. You have a balloon and you have some solid material, some hard plates, some knives, some, you name it, depending on the balloon, just placed on it. And then you're trying to modify and crack and infuse more cracking in your calcium. That's the first maybe thing that is. Another thing I will show, I know Dr. Shahid already just showed us rotational, RotaPro, you know, is the newest improvement, no more pedal, just a new device. This is orbital atherectomy. And orbital atherectomy is available now. It made it to Lebanon. Unfortunately, I don't think any case is done yet, but the machine made it to Lebanon. And I think it was stuck for a long time with all the curfews in the
Only the machine.
Only the machine, the catheters, but we just have to do the first case. Yalla. So basically, it's simple. You have all the controllers in that device. You can see the device, the pump that you put on a pole. You don't have a pedal in it, and you have its special lubricant, the Viper slide. And the concept is simple. It is basically the idea is to do this, what they call differential sending. It has this wobbly motion because it's not your basically your rotational atherectomy. You have your diamond there going at the front. You have a 6 millimeter lag, which has its pros and cons, you know. And I'm pretty sure Dr. Edis will talk more, but non-crossable lesion, nothing beats rota. You go, you pack. You showed it beautifully, you know. You pack, and then ultimately you drill that tunnel and you go. Here it's a bit different. The idea is that with this wobbly motion, it will have some shaving, that continuous shaving, and it can do this, what they call sanding, small particles, less no reflow theoretically, but more importantly, inducing cracks in the calcium itself, so that when you later take your non-compliant balloon, it can have an effect. You know, I think it's, if you tell me where this is probably best for the nodules, you know, if you ask me nodules, because nodules, you know, with the guide by ROIs, sometimes you can't just do a lot, you know, I mean, with rotation. But that's the modality, that's the device, and that's how it works. Concept is pretty simple. You just saw it. It's not centered. That is not totally centered, and that's why you will have this wobbly motion in it. And that's, again, orbital atherectomy, CSI. You can do it back and forth. You know, there's no direction. I know in rota, the big bursts, you know, you can, I mean, you will not be stuck. But basically, another modality worth showing. Next is shockwave. Shockwave, you know, probably the thing really that made shockwave so easily accessible to everything is the fact it's a balloon. You know, all of us, you know, balloon angioplasty starting with balloon angioplasty, and it's a balloon. It has these emitters, and these emitters will basically emit shocks. You know, you can see the setup is quite easy. Um, I'll show you this is in this 1 minute movie we're reviewing together. The idea and the concept of these. You know, shockwave was initially the developed. Initial cases were for the periphery, so in peripheral intervention, different types of devices. You know, the, 4 and 5. I mean, this is the coronary device, and the idea is simple. You go, you inflate it, and you will start sending these waves, these shock waves, as the name implies, and it's not, you're not doing balloon angioplasty here. You're not going to high pressure. The recommendation is to go 4 atmosphere, 6 atmosphere max, and then you're sending these shocks. You know, you can see here clearly on your inflator, you have 4 ads, and you're sending shocks, and each catheter has a certain amount of shocks, you know, that you can deliver. And the idea, especially for deep calcium, it will cause it is lithoplasty. You know, it is the same that's been used before, but now you're using it in the coronaries. Yes, it is. You are obstructing when you're doing it. You know, so that was what also was mentioned in the case where your patient is crashing on the table. You go, you need water, you need to drill it and go and finish it. Here, you sometimes you don't have the luxury to tolerate seconds and sometimes long seconds with a crashing patient of these happening. And ultimately, you see the lesion yielding. Yet, as was mentioned earlier, even when you do it, non-compliant balloon after it, you know, some of us take the shortcut when you do it, and you know, you saw it already yielding. You just think of it as a balloon. Your catheter is done, it's going to be tossed, you know. It's not recommended, but you just inflate it to high pressure, but it's not usually recommended. And that's the movie demonstrating basically in contrast how it is. And next on the right side, this is a chalk, you know, tapshur basically. It's chalk that is wrapped around the catheter, and you can clearly hear you see this, and then ultimately it breaks. So I mean, that's the concept of shockwave. So rotational atherectomy, orbital atherectomy, and that's basically shockwave. Last one is laser. So this was a laser we did when experimentally when the BVS still in training. This we did it actually on a BVS. We're trying to see basically what laser will do to a BVS. This is not I mean, obviously this is a bench done in an experimental lab. Do not try this at home, you know. Exactly, you know, unless you want to blow it up and cause another well, the sport. Of course, we're joking. هذا اللحام بتجيب البيش ولحمه بهيدا. So anyway, ELCA is that laser atherectomy, and honestly, I've used it in training. I don't think it's available in Lebanon. I've used it in training. It's a bulky device. It's the only time, you know, we were excited about it, and I'll mention it, and it almost fell out of use, you know. The only time we were really excited about it was when VVS came out, and before, and we're talking, this was 2015, 16. We were excited into these patients that had in-stent restenosis and had already 2 layers of stent, you know, or sometimes in-stent restenosis and 1 layer of stent. And we used to image and say, can we debulk a bit the neointima? You probably know in the United States, drug-eluting balloon did not exist, still do not exist, and probably will not exist for a certain amount of years. So what the rationale was, you go, you just put that laser, you laser a bit, you modify the neointima, and you go and put the BVS and just expand it as much as you can, you know. Try to embed these bulky struts. You know, we all later knew these are bulky struts. They will protrude, they're thick, they will cause potentially thrombosis. But during that time, we've done in even probably around 50 cases total of in-stent restenosis, stent failure, laser. But again, you saw how RotaPro now is smaller. You know, the CSI comes on a pole. This is a huge device, a huge and heavy device. You know, still being used in One thing to mention, I did not mention it. When you're doing it, you're flushing with saline. You know, flushing with saline, you have to have short runs, slow advancement, 1 millimeter per second almost. So, you know, all these things are not super welcome in the coronary space. You know, flushing with saline, keeping this catheter for a long time. Of course, you're anticoagulated. That's why peripheral intervention, you can do anything on that CLI below the knee, but when that critical limb ischemia, but when you're doing it in the coronary, it has to really be justified. Before the invention of shockwave, I think the biggest excitement for this was probably when you have in-stent restenosis and calcium caused by an underexpanded stent with calcium behind it. You know, so you know either you had to go rota and shear it out and just you know destroy the struts and put a new stent, or you can try sometimes. And some people again do this what they call this like bomb combo, you know, they put contrast instead of saline when they're flushing, you know, and with the idea is you know, when you're sending these laser waves, they can do more. So briefly, this is I mean all the modalities. I'll show in my last two slides the effect of these, you know. First one is you know, published. This is A and B. A was a cutting balloon. You can clearly see the cut was there where my arrow is, but sometimes you're able to cut when it's a thick calcium, sometimes you're not able to cut. And then I'm sure you'll hear your opinions later about it. But the cut will always happen at the weakest link, you know. Similar concept when you're using POBA, plain old balloon angioplasty, on a chunk of calcium, the rest of the vessel is normal. You go, you crank your balloon up, you'll have luminal gain, you're happy. But a lot of time, you're gaining it by just dissecting the edges of the calcium. The calcium is untouched, and you get luminal gain by just hitting the edges. And the second one is the picture that we should keep in our mind. Do not do this. The rotary graft, whatever. But this is in picture, you know. And it's always when it's in picture, you always say it's your colleague's case, not your case, never your case, right? So, but this is it. A thick, nasty circumferential calcium stent is implanted. And you can clearly see that stent between 3 o'clock in panel D here, I'm talking between 3 o'clock and 7 o'clock, hugging that catheter, it's not able to expand. And at that stage, you're stuck. You just implanted a fresh stent. You can't do any more the atherectomies, the rotational, orbital, you name it. You will not laser or shockwave a freshly implanted stent. And a lot of time, you just battle a bit with the balloon and then end up calling it a day and hoping he will not thrombose and that you will deal with restenosis later. Next is the effect of rotational. This was clearly a thick calcium in panel A, rotational atherectomy, drills a tunnel. You can clearly see, you can almost draw that where that burr passed. The burr was bigger than the MLA. This OCT catheter is 1 millimeter. So you can clearly see that using a big burr, we drilled a tunnel. It thins the calcium, induces some micro cracks in it, and then later you go and you take that high pressure balloon and do what needs to be done. And lastly, the orbital, as I told you, that selective sanding, that shaving, you can see the footprints where it passed on this like bit of a nodule, a bit protruding into the lumen. You can see it in panel C, and it did its work there. So my final thoughts, I think imaging is essential to define the calcium burden. All these, except probably the laser, are available today. You know, I know we're struggling a bit these days, but we're hoping for a better tomorrow. So rotational, orbital, shockwave, OCT, IVUS. You know, not in every institution, but combined. You know, it's a combined effort to, after all, serve the best our patients. So some of them are available at Ali's place, some of them at Raji's place, some of them at Malik's place, some at Abdullah's place, some at our place. But ultimately, hopefully, we just hope for some improvement in the reimbursement, because that remains a challenge on how much we can use these. No single plaque modification therapy will win. We should choose the right tool for the right calcium. This is what we're setting up the talk here of Dr. Edis, the right tool for the right calcium. Sometimes a combination of modalities is necessary. And in 2021, I don't think guessing is allowed. We should image, prepare, and define our success. So with this, I want to thank you once again. And of course, we'll take any question you or the people online have.
Wonderful. Thank you very much. I mean, this is as good as it can get, very comprehensive. And I guess I'll leave the floor for questions and see what any comments Dr. Aris might have.
Excellent talk, Dr. Mahana. I very much enjoyed listening to it this afternoon. As a matter of fact, it also almost leaves my talk a bit unessential afterwards, but I'll do my best to make up for this.
Thank you. Thank you. No. I told you, we're just setting the floor up, you know, for you. We're all looking forward and we really want to thank you for your presence joining us tonight.
Sure. I'm happy to be here.
Dr. Muhammad, any final comments? Think with that.
Thank you, Emil. Very well done.
Excellent. Thanks again. Okay.
Thank you, Emil. Dr. Aris, the screen is yours.
Thank you. I think we can see it now. Very good. So updates on calcium treatment algorithm. So first of all, I'd like to point out where I work and why I'm here today to explain my interest and my knowledge in the subject. I work at the Sunrise University in Budapest, Hungary, located in Central Europe. This is a tertiary university hospital that's been active for almost 100 years of patient care. We have lots of beds, lots of ICU and sub-ICU beds, and the full spectrum of cardiology, vascular surgery, and of course, cardiothoracic surgery. We have an ACS hotline 24/7. We're handling the cases all day, every day, 24/7. Altogether, we have 14 doctors at the moment, 6 of them seniors. We're also the Hungarian National Center for Mechanical Circulatory Support, and at this time, we are the only center in our country that routinely does acute extracorporeal membrane oxygenation and handles these cases. We're also the shock center of the nation's capital. Budapest has a population of almost 2 million people, so this is what we have to handle. We do more than 3,500 PCIs per year on 2+2 beds, and our institution has been a rotational atherectomy proctor since 2003. This is a map of Europe, and you can see where Hungary is located to get you situated. And now to get on to the bulk of my talk. You've heard the term benign coronary artery disease many times, I think. Usually they say that a fixed obstruction in the coronary artery may be severe or not so severe, with the prior name of stable coronary artery disease. Nowadays we call this chronic coronary syndrome. Is not really that big of an issue because it's more or less stable and it does not cause that big of a harm. Calcium, as everybody knows, coronary calcification causes a true problem to us interventional cardiologists, because the more we see it, the more it impacts our work. Usually these nodules that we see cause less adverse events in patients as compared to highly lipid-rich lesions, yet some form of ACS also involves calcific nodules with ruptures of these microcalcium fractures inside, leading to acute coronary syndrome similar to fatty plaque rupture and acute coronary syndrome. Therefore, I would call it an end-stage coronary artery disease, the highly calcified coronary artery, which can yet lead to severe consequences in terms of acute coronary syndrome. Why is this such a pain in the head? Because it's usually extensive, it involves numerous coronary segments and numerous coronary arteries. It's difficult to manipulate, it's resistant to classical PCI methods, it sticks and it breaks. Everybody knows who works in interventional cardiology what sticky and breaky means in these cases. So what are our available options? We've heard excellent talks thus far. I'd like to gather these a bit and show you how we in Budapest have developed an algorithm to work through these to the best interest of our patients. What I in my cath lab have very, very strongly said to every one of my colleagues that if native coronary artery is visible on an angiogram, then extremely thorough vessel preparation is required. And beware, if you fail to comply, that would be a terrible mistake on your part as a doctor. The choice of lesion preparation devices depend on a multitude of factors, as we've heard from Dr. Meana, and often requires more than one method for us to get the best results possible. The general idea for lesion preparation is the following. Only consider advancing your stent if you are convinced that you will be able to deliver it, first of all, and then deploy it fully and safely, and be able to retract every part of the device of the stent carrier afterwards. How do you approach a calcific lesion? Classical pre-dilatation using balloons of whichever type and make you wish can fail for two reasons. One is so-called BTF and one is BEF. It's either transmission failure of the device or expansion failure of the device. This is where dedicated instruments are required. The rotational atherectomy is one of the excellent choices in this matter because it's indicated for both of the problems. Also transmission failure of the balloon and expansion failure of the balloon. Of course, you have to adjust the burst size for each individual problem that you see, but you are able to fix a multitude of scenarios using only the rotational atherectomy. The cutting balloon microtome and the shockwave intravascular lithotripsy system is indicated for balloon expansion failure when you are able to advance your balloon, but have the hourglass phenomenon. We've heard lots and lots of the orbital atherectomy. I'm a bit envious because I have not had the chance to try the orbital atherectomy as of now because it does not have the CE mark yet, meaning it can not be distributed in my country, but I look forward to using it as fast as possible. I have hopes that it will be available this year and I will be able to use it for the benefit of our patients. We also heard of the laser atherectomy system. We do have the laser atherectomy in Hungary, but it's rarely used. As we've heard, it's extremely bulky, it's difficult. Usually when we use it is for CTO PCI when there is an extremely stenotic and very, very heavily calcified lesion that is resistant to almost anything. That's where we use the laser atherectomy. A colleague of mine working in the south of the country is the one that leads this operation. I myself have only tried it once. And a few thoughts about the microtomes and the shockwave balloons. I'm happy to tell everyone that the first microtome introduced, which eventually became the flextome balloon, this was an invention of a Hungarian man named Barát Péter, who immigrated to the United States and developed his system there, eventually selling it to Boston Scientific. And the flextome balloon was used for multiple years, almost 30 years. And now it evolved into the Wolverine coronary cutting balloon system, which is much less bulky than the original one, preserving most of the benefits of the system. We've also heard from Dr. Meana about the IVL, so the intravascular litoplasty system. I don't want to say everything again. It's a system with lithotripsy emitters in which a balloon is expanded and fluid inside is paced via the sound effect, and it creates a rapidly expanding bubble which cracks calcium. It has to be mentioned very, very strictly that this is only for calcific lesions. Fibrotic lesions do not benefit anything from IVL. And IVL is only indicated in stable patients in elective cases. Acute coronary syndrome, especially those with cardiogenic shock, present strong contraindication to IVL therapy. And today's probably best known and most widely used and definitely the most studied method is buzzing or drilling the plaque via rotational atherectomy. The question always arises, and the one that I get from my residents and those doctors where I go to proctor rotational atherectomy is when and how do you use rotational atherectomy? Now, the traditional old era answer was whenever you think that it's needed. This option still works about 80% of the times. These are two very typical Hungarian cases that I see in my everyday practice. Both are frightening. Both patients are luckily doing well. But now in the 2021, we have, of course, options available to us that are way, way more scientific than the one that I just told you about. As we also heard in the prior talk, imaging is key. Why? because seeing is believing. That's why. This is short but very direct algorithm of what we use in Budapest. If we see a severe calcific lesion on the angiogram, we definitely perform an IVUS. We prefer IVUS because of the fact that the new catheter itself is easier to manipulate than the OCT catheter, and it does not require excess contrast material, very simply. As you can see, if you're unable to cross with an IVUS, that shows us, or the lesion up front is very tight, then we rotablate up front and then IVUS again. And determine the IVUS characteristics of the lesion, we always look at the arch of the calcium, what we see. If the arch is more than 100 degrees, that means more than 2 quadrants or reaching 2 quadrants, then we consider that severe. If it does not reach 180 degrees or 2 quadrants, we consider that moderate. If there is definitely a high arch in calcium and the stenosis is severe, we rotate up front. If it is moderate, then we additionally prepare the lesion as needed, be it NC balloons, scoring balloons, microtomes, or IVLs. We of course apply then the stents as necessary when we are sure that we will be able to do this, meaning that transmission of the stents and expansion of the stents will not prove a problem, and we IVUS optimize the stent as needed. I have to say that upon IVUSing the stents placed in a calcific lesion, more than 50%, so more than half of the stents that are well implanted angiographically do need optimization as per the IVUS assessment. And which are the rotational atherectomy systems that are around today? We have the older Rotaling legacy system that we've heard about. This system has given us 30+ years of extremely dependable service. It has saved countless lives, and many patients owe their lives to this machine that we see on the left. It is stable, reliable, it is cheap. The only downside is that it requires 2 men to operate. So either 2 doctors or 1 doctor and a skilled nurse who is also able to cope with the system. The new RotaPro that you see on the right, this has evolved from the prior 30 years of experience that we've had with the legacy system. It is without the pedal that you see on the left, right here. The pedal is has been exchanged to this small button that's on top of the advanced server. Therefore, it is a semi-automatic system, and it only requires 1 operator to use. The nurse is not necessarily needed, and the whole machine itself is a new-looking, stylish 21st century interface. The newest question that I also get is, who should rotablate, and what are the results of rotational atherectomy? Well, a senior and most experienced interventional cardiologist is required, and one who has received dedicated training from a specialist, either from a specialist center or a specialist course. Depending on lab volume, I'd say a maximum of 2 or 3 operators per institution is enough. You have to be handy with rotablation. You need experience, and the only way to gain experience is to do cases. That means that with the, I'd say, maximum 4 to 5% of rotational atherectomy that is currently needed. Of course, this number can be debated. Like I said, a maximum of 2 or 3 operators per institution is enough. I highly recommend the proctor involvement in the additional at least 10, but preferably 20 cases, especially if these are more difficult ones. Because these 10 or 20 cases, they will be mostly enough to run into the most difficult essential problems and the one that needs to be fixed immediately. And an operator will have enough experience after these initial cases to start his or her own practice. Our success rate in Budapest, Hungary is over 90%, according to this article that I showed you, and our long-term results are very much acceptable in this case. Also, commonly I get the question, when do you ask for expert help? So when is a tertiary center required for help? An excellent question, and these are the 3 situations in which I consider are absolutely necessary for the patient to be transported to a center who has at least an expert operator in rotational atherectomy. The first one is left main rotablation, especially if the bifurcation lesion is involved and it needs dual direction, so left main circ and left main LAD rotational atherectomy. If the patient has decreased left ventricular function, especially if mechanical circulatory support may be considered for an operation, and of course in bailed out situations, for example, the stent ablation. We're able to write a very good paper on stent ablation. If you would like to see it, have the time, please take a look. You see it here in the middle. This is one of the biggest rotary graft phenomenons that you can think of. And the main message of our paper is do everything you can to avoid additional stent ablation because it's extremely bad for the patient. Few tips on wire escalation. I think floppy wire that is much more benign than the extra support one works in 90% of the cases. If wire escalation proves a bit difficult, then you can place a standard pathfinder wire, which makes it easier for the rotawire to find its place. And as we saw in the first case, a microtome change is always a good idea if you have difficulties wiring with the rotawire. Which burr, which should be the standard? Now, there has been a large change in the introduction of new generation drug-eluting stents in the burr size that needs to be used. I'd say 20 years ago, before the era of drug-eluting stents, a 0.7, 0.8 burr to artery ratio was recommended, meaning that the only thing that needed to be done is drill the coronary artery with a large device, and then our work is done. Luckily today, this has shifted to a debulking plaque modifying technique, meaning that I recommend you start with small burrs. The 1.5 millimeter burr is optimal about 80% of the cases to begin with. Use the standard 140 to 160 K per minute RPM for burr runs, and the burr runs themselves should not last more than 15 to 20 seconds because of heat generation. And if you do not penetrate the lesion after 4 or 5 runs, increase the speed to 100 or 200,000 K. If you are still unable to penetrate the lesion, then downsize the burr to the minimum of 1.25 millimeters. I've did several hundred rotational atherectomies in my case. I only experienced one single case when the 1.25 burr at 200 K per minute did not pass the lesion. So only one. I remember it was an old lady. I remember her very well. And that was the only case where there was no penetration of the smallest burr at maximum speed. There are 2 burr handling methods. On the left one of the picture, you can see the pecking method. And on the right side, you can see the hammering method. I prefer the pecking method, which is much more slower. It's gradual. The hammering method also has a couple of drawbacks that I will just talk about, which is burr entrapment, or the so-called Kokeshi phenomenon. This is when the burr jumps through the initial lesion, and you have to know that the proximal part of the burr does not spin, only the distal half of the burr spins. And if you jump through a lesion, you will have a very, very difficult time with burr entrapment, because pulling it out and removing it is a very, very problematic issue. There are very, very nice plus points for the RotaPro system because it warns you of an imminent stall and an imminent entrapment of the burr. You can see these yellow squares. If there is a drop in the speed of the burr, the system will warn you with these yellow triangles, which you can see. If it is below 5K, it's an open triangle. If it's above 5K, then the yellow triangle is full. So as I said, use the pecking technique. That's what the expert consensus says. Start with small burrs and use mid RPMs for best results. These are the APSI, so the European Society of Interventional Cardiology assessment, which is headed by Emmanuel Barbato, who's one of my colleagues whom I trained with a couple of years ago. Now, rotational atherectomy in the 21st century, how should we use it? It's living a very, very nice renaissance with the old comorbid patient populations that we see, and it's often the only option to help our patients. And without this system, we cannot revascularize the patient, which means the patient has no survival. The new RotaPro system is extremely good. It's very handy. It mitigates a lot of problems that the old system had. I wouldn't even call them problems. They were basically a nuisance. But now with the new system, these can be bypassed, and it's very, very comfortable to use. Dedicated training and proctoring is definitely required, but in trained, experienced hands, it's an extremely safe method, and it can treat otherwise incurable coronary pathologies and thus save a plethora of lives. And if I still have some time, I'd like to show you a typical case that we have here. It's a 66-year-old female presenting with CCS4 angina on routine medication, and an initial angiography performed in another cath lab showed a proximal LAD D1 highly calcified stenosis, and the patient was scheduled for LAD PCI using whatever method was necessary. Our trouble began where we were unable to advance our guide catheter to the radial artery. Therefore, we had to switch to the femoral artery. And here you can see this multitude of calcification on the proximal LAD. This is the angiogram, and we performed the IVUS on this patient, which showed deeply running calcific lesions on one part of the coronary artery and an almost 180-degree arch on the other type of the artery. The bifurcation itself showed a severely stenotic lesion in the main branch, which did have an excess of calcium. And the lesion prior to that showed a severe 180-degree arch of calcium, which has penetrated into the lower levels of the stent. Therefore, what we started initially with the rotational atherectomy of the vessel. It was a 1.5 millimeter burr, and around the second or third run with the burr, I was able to pass the lesion. I IVUSed it again, and note the debulked calcification in this PLAD D1 bifurcation right here. But the larger vessel prior to that was unaffected with the rotational atherectomy because this was a 1.5 burr. As we've talked about it prior, this burr probably only spun right here in the middle of the coronary artery and did not even touch this part of the artery, meaning that this part, the proximal LAD and D1, was significantly modified enough for us to continue with ballooning, but this part was not. This needed additional treatment. What we did right here, we used a 3.015 Wolverine microtome. You can see it expanded on one slide and the other slide. The entire vessel was ballooned with this cutting microtome, and we did a third imaging afterwards. And this is a very, very significant picture that you can see with the crack right here and right here of the calcified lesion that we see. And this is the fractured proximal LAD calcification after Wolverine microtoming. Even after this, we proceeded to balloon the vessel with an NC balloon. And then finally, I was quite comfortable with advancing my stents. 2 stents were needed in this clinical scenario with this patient, all the way to the ostium of the LAD. And as you can see on the lower part of the slide, we had quite a good IVUS result, which was also accompanied by quite a nice angiographic result. Atherectomy post-dilation of every stent is definitely required. So take-home message with this case is that the distal lesion was tight, calcified bifurcation, which needed rotational atherectomy. I used the Rotapro in this case because luckily we have it available. The proximal lesion was very calcified. It was big, so it needed the Wolverine to have it sufficiently correct. And using both technologies, we were successfully able to prepare the lesion, and stent expansion proved effortless. And we had a very nice gain of lumen after the procedure. Post-PCI IVUS displayed and an excellent apposition of the stent. Thank you very much for your attention. You can see a sunset at the Lake Balaton in Western Hungary and my contact info. Thank you again.
Thank you very much, Dr. Aydis.
Thank you, Dr. Aydis. There are no questions till now. Dr. Malik and Dr. Abdullah, if you have any comment, and the concluding remark by Dr. Malik.
Just a small question. Obviously, you're a huge volume center, but how often do you resort to using guide extension to avoid proximal tortuosity involvement by the rota, and when you have a mid to distal lesion, and in that case, do you upfront go to a 7 French, 6 and a 7, so a 7 French guide, 6 extension for ease?
A couple of years ago, before we had the Rota Pro, we did use it, in fact, and we did use the 6 and the 7. With the new system, our life got much easier because it's much more delicate, and it's easier to maneuver around tortuosity without eventual problems. So nowadays, it has become a bit more rare. We still have 1 or 2 cases, but not as many as let's say 5 years ago.
Dr. Aidis, are you using it not routinely for instant restenosis, which are so old, very late? And another question for saphenous vein grafts. Is it also amenable in your center? Do you encourage us or not?
I do encourage the use for instant restenosis in cases where you see calcium inside the stent. So neoatherosclerosis, which is calcified, is very difficult to treat. So that's even a bit worse than native calcification in the coronary artery because of the fact that the vessel is already caged and therefore much less prone to either type of manipulation. So if we see calcium inside the vessel, and usually this is only the case with older bare metal stents, but we have lots and lots of patients here in Hungary living with older type of bare metal stents, then I do recommend rotational atherectomy. It's the venous grafts that's a problem. It's a relative contraindication to rotational atherectomy. I do not say that I haven't done it before, but I do not recommend doing that unless you're very, very skilled and you consider yourself up to the task. And another important thing, you have a sufficiently large stent graft at your disposal because those are much more prone to rupture.
We've passed over in STEMI and unSTEMI cases tonight, and both had underwent atherectomy. I've learned that also atherectomy is relatively contraindicated in thrombotic lesions, and these 2 cases are best of thrombotic lesions. One is STEMI, and the other is nSTEMI with the high-grade high troponin and cardiogenic shock. What do you say about the safety in these cases? And if there, especially here in the shock case, we couldn't use any hemodynamic elements like nitroprusides or adenosine. Also, it is risky in a patient who is unstable. What can you say about these comments?
Yes, I agree. Now, the problem with thrombi is the following, that if you start buzzing, so drilling the thrombi, that will definitely fragment the thrombus that is there, and it will cause distal embolization, probably leading to a no reflow phenomenon, which should be avoided. Now, in the cases that you showed, the first case, luckily the thrombotic occlusion was the CIRC and not the RCA. The RCA there was probably also more or less of a chronic nature, which of course decompensated during the inferolateral STEMI. With the second case, the first of the 2 lesions may have been more or less thrombotic. The distal one was also, I consider it to be a bit more chronic, which also had an acute component on it. If you see visible large amount of thrombi in the coronary artery, I have not resorted to rotational atherectomy until I can remove that more or less. Usually what we see is that the lesion that has the large amount of thrombi is not the one that requires a rotational atherectomy. It's usually the one that's downstream, so more distal to it, meaning you can suck it out with a thrombectomy catheter or the guide itself. I do not like really thrombectomy catheters because I don't think they're too efficacious, so nothing happens when I use it. So what usually I use is I advance my 6 French is the guide that we usually use as workhorse. What we do is insert a 5 French guide inside it, and that's what I use for to aspirate. So a simple tube, and that's the one with the one I had the best results. And after this, if you can debug a large amount of the thrombi or remove a large amount of the thrombi, then you're ready to ablate the remaining calcific lesions.
Thank you very much.
Thank you.
Thank you. Abdullah, عندك شيء?
That's very, very clear to me. All is good.
Thank you very much. Okay, I would like to wrap up first by thanking you very much, Dr. Aidis. It was an honor, and we were proud to have you with us, especially in the elegant talk that you have given. I would like also to thank Abdullah and Ali for their moderation and preparation, and for the two elegant cases also, which were presented by Emil and Radi. Thanks a lot. We've learned a lot from these cases, and I hope all of us had this advantage. I would like to conclude that PCI of heavily calcified lesions represents a challenge for all of us as interventional cardiologists, because it has a high risk of immediate complications and of late failure that will end up by stent under expansion and malopposition. This will definitely lead into a poor clinical outcome, and saying that high MACE and high mortality rate will be the result. We are living in a poor economic status in our country, for a pity, and definitely we know that multimodality imaging is the key, as we've learned from your talk and from Emil's talk. And it's a pity we cannot have it available in all centers because of the reimbursement issue and because of the availability of this machine in all labs. We will definitely know that calcification is associated usually with advanced age, and we have an aging population nowadays, which we are facing in our lab more than previous eras, and that's why this problem is becoming more and more for future events in our labs. And definitely not to forget diabetes, chronic kidney disease, which we are also facing a lot with dialysis patients having heavy calcification and burden in our lab also. I would like to say that having substantial technical advancements in the treatment of heavily calcific lesions for the past few years improved our procedural success, and it also lowered the peri-procedural complications. And this was due to the combination of all the methods that you've mentioned with Emil, especially in his talk, which was very comprehensive concerning the NC balloon, the scoring balloon, the cutting balloons, the rotablator, which I can say that it will and it still remain to be the gold standard in this scenario of heavily calcific lesions, because it will bypass the non-transmissible and the non-dilatable lesions, which usually we are facing in heavily calcific lesions. So it will remain, and it remains to be the gold standard. I hope we'll have more practice and more hands-on or experienced operators, so as to get the high success rate and low complications. And I hope it will be reimbursed also, because we have an issue concerning the reimbursement of these techniques in our country. We benefit a lot from your talk, and we were proud to have the experienced person that we've learned from, as you, Dr. Aidis. And this is definitely for sure will be our challenge in the future, along with the key modality imaging because not every lab in our hospital has the capability of having the IVUS or the OCT. Especially these are key elements in having success and in planning for our case, as far as the length, the arc, and the depth of the calcification that should be planned, seen, and accordingly taken care of. I would like to thank you all. This is all what I have to say, and we hope the best for you. And I hope you will be safe, healthy in this COVID era we are living. Thanks again, and hope to see you physically in the near future in our country, Dr. Alex. Thank you, Shabir.
Thank you very much. I look forward to visiting when possible.
Hopefully.